Acute fulminant myocarditis is a rapidly progressive and life-threatening form of myocardial inflammation characterized by sudden onset heart failure, severe hemodynamic instability, and often cardiogenic shock or malignant arrhythmias. Unlike non-fulminant acute myocarditis, fulminant myocarditis requires aggressive intervention including inotropic support and mechanical circulatory support to bridge the patient to recovery or transplantation. Diagnosis of fulminant myocarditis requires a high index of suspicion due to its ability to mimic acute coronary syndrome. Patients typically present within 2 to 4 weeks of symptom onset with rapid deterioration. Symptoms may include severe dyspnea, chest pain, and signs of low cardiac output such as cool extremities and narrow pulse pressure. Cardiac troponins are almost universally elevated. Recent studies indicate that the Sequential Organ Failure Assessment (SOFA) score more than 12 and significantly elevated CKMB more than 94.7 nanogram per ml are strong predictors of in-hospital mortality. Echocardiography typically reveals severely reduced left ventricular ejection fraction and often increased wall thickness due to myocardial edema rather than hypertrophy. The 2025 ESC guidelines provide a Class 1 recommendation for cardiac magnetic resonance imaging in suspected myocarditis. It can identify edema and late gadolinium enhancement. Notably, the presence of myocardial fibrosis on cardiac magnetic resonance imaging is associated with a lower likelihood of ventricular recovery. CMR is recognized as the definitive non-invasive tool to confirm myocarditis, capable of distinguishing between reversible inflammation and irreversible fibrosis using the revised Lake-Lewis criteria. Endomyocardial biopsy remains the gold standard for definitive diagnosis and for identifying specific subtypes like giant cell or eosinophilic myocarditis that require targeted immunosuppression. The ESC 2025 updates emphasizes its use in high-risk presentations where a change in management is anticipated. Management focuses on maintaining systemic perfusion while minimizing myocardial work. Mechanical circulatory support. We know arterial extracorporeal membrane oxygenation is the primary support modality for refractory cardiogenic shock, with survival rates reported around 60 to 70% in specialized centers. Left ventricular unloading. To prevent left ventricular distension and pulmonary edema during VA ECMO, early unloading using an impeller device or an intra-aortic balloon pump is increasingly utilized. Pharmacological and immunomodulatory therapy. Inotropes, vasopressors are used for initial stabilization, usually involving norepinephrine and dobutamine. High-dose intravenous methylprednisolone may be considered particularly in refractory cases or virus-negative inflammatory cardiomyopathy. Myths. Myocarditis therapy with steroids trial is evaluating efficacy of pulsed intravenous methylprednisolone versus standard therapy on top of maximal support in patients with acute myocarditis. The trial is ongoing. IVIG. While controversial, high-dose intravenous immunoglobulin has shown dramatic improvement in selected cases, potentially due to its anti-inflammatory and antiviral effects. While fulminant myocarditis was historically thought to have a superior long-term prognosis compared to non-fulminant forms, if the acute phase was survived, recent registry data suggests in-hospital mortality remains high even with mechanical circulatory support. Long-term recovery. Many survivors exhibit residual left ventricular dysfunction. Factors such as prolonged ECMO duration and extensive fibrosis on CMR are negative prognostic indicators.